Hi, today I'm going to present to you the study Testosterone Patch for the Treatment of Hypoactive Sexual Desire Disorder in Naturally Menopausal Women. Results from the Intimate NM1 study. The study was published in 2006 by Schifrin et al. From the reading, you learned that entering menopause has a huge effect on sex drive in women. Specifically, menopausal women experience decrease in sexual desire and arousal. The medical term for this condition is hypoactive sexual desire disorder. I'll refer to it as HSDD from now on. By definition, HSDD is decreased interest in sexual activity that causes distress. The reading also mentions that hormone therapy is used to treat menopausal symptoms. It's often supplemented with testosterone to increase sexual desire, which results from HSDD-like symptoms of menopause. This study focuses on that testosterone supplementation portion. Specifically, it examines the efficacy and safety of the testosterone patch for the treatment of HSDD. In fact, this is the first ever clinical study to test testosterone patch HSDD treatment in women who enter menopause naturally and who are concurrently on hormone therapy. By entering naturally, I mean without surgical removal of the ovaries. Participants were 549 healthy menopausal women aged 40 to 70 years. They were recruited from 58 centers across the U.S., Canada, and Australia. There were several criteria for participation. First, the women had to have entered menopause naturally. They had to have been on menopause for at least a year. They had to have been receiving hormone therapy for at least 3 months. They had to have been in a stable monogamous relationship with a sexually functional partner for at least a year, and they all had to have had HSDD. The women were randomized into a placebo group that received a placebo patch and a testosterone group, which received a testosterone patch. The patch was placed right above the abdomen as pictured here. It was placed there twice weekly for a total of 24 weeks. The testosterone patch administered 300 micrograms of testosterone per day, twice weekly for 24 weeks. The testosterone would seep through the skin into the blood. The placebo obviously did not receive any testosterone. Sexual activity and function were determined based on 2 self-reported questionnaires administered to both groups of women. I'll first talk about the sexual activity log, discuss its results, and then move on to the second questionnaire. The sexual activity log was administered pre-treatment and then weekly throughout the 24-week treatment period. Its purpose was to assess frequency of sexual activity, specifically sexually satisfying activity, total sexual activity, and total number of orgasms. It asked about these frequencies for the past 7 days. Let's take a look at the results. This graph shows results from the sexual activity log for the last 4 weeks of the treatment period, so weeks 21 to 24. On the x-axis, we have total episodes of sexually satisfying activity, total episodes of sexual activity, and total episodes of orgasms. On the y-axis is the mean change from baseline. In black we have the placebo, and in white we have the testosterone patch group. All p-values indicated that between group differences were statistically significant. Keep in mind that this is mean change from baseline. So for example, for the orgasm group, the testosterone patch group had 1.7 more orgasms over a 4-week period compared to pre-treatment. The placebo group similarly had 0.5 more orgasms than pre-treatment. As you can see, all aspects of sexual activity increased significantly in the testosterone patch group compared to the placebo group, the highest being in satisfying activity, and then orgasms, and then total activity in general. This graph shows that women on the testosterone patch had sex more frequently, but that the predominant effect was that the sex was more satisfying. The second profile for a female sexual function survey was done pre-treatment and 4, 8, 12, and 24 weeks. This asks about sexual feelings of women for the past 30 days, specifically for 7 parameters: sexual desire, arousal, orgasm, pleasure, concerns, responsiveness, and self-image. Higher scores on each of these parameters indicate better sexual function. Let's take a look at these results. This is the identical graph to the graph before, except that on the x-axis, instead of total episodes for each category, it's the total score. So an increase indicates improved sexual function for that category. Women on the testosterone patch had statistically significant increases in sexual desire, sexual arousal, orgasm, sexual pleasure, had decreased concerns, increased sexual responsiveness, and increased sexual self-image based on these results. I'd like to point you out to the decreased concerns category. As I said, personal distress is a major determinant of HSDD, so it's very interesting to see that the testosterone patch actually decreased concerns way more than the placebo group. These results indicate that for all parameters of sexual function, the testosterone patch actually found to be very effective compared to placebo group. To summarize, the testosterone patch increases all parameters of sexual activity and sexual function relative to placebo in women who enter menopause naturally and who are experiencing HSDD. This includes an alleviation of personal distress for a testosterone patch group, which I mentioned was a major determinant of HSDD. One limitation was that they did not distinguish by age. Women were 40 to 70 years old, as I said, and as you age, you naturally have physiological symptoms associated with aging. It might have been better to do an age breakdown of the results to limit any confounds. Also, long-term safety of the testosterone patch was not assessed. They did not see past the 24-week period if there were any potential side effects. This study has tremendous biological significance. It's a treatment for the suppressed sexual desire postmenopausally and has great implications for improved quality of life postmenopause. From an evolutionary perspective, we know, as Sonali mentioned, that humans have a lengthened post-reproductive lifespan. The leading hypothesis in this is the grandmother hypothesis, and as I'm sure you're all familiar with. Basically, this lengthened period of post-reproductive life increases reproductive success for the grandmother, allowing her to alloparent for her grandchildren. There is an adaptation in this period for decreased sexual desire. This drug, essentially, this testosterone patch, is going against this evolutionary adaptation by trying to fulfill the sexual desire post-reproductively. Future directions would be to assess long-term safety effects of the testosterone patch. It would also be interesting to look at higher doses of testosterone and see if these have steeper effects on alleviated symptoms associated with HSDD. It would also be nice to see if there are similar effects with women in postmenopause who are not on hormone therapy. There is a patch mentioned in your reading called Intrinsa, and it has not been FDA approved in the US. However, it's been available in Canada since 2002, so this shows the potential of this patch as treatment. To conclude, this was the first ever clinical trial to show that the testosterone patch increases sexual activity and function in naturally postmenopausal women. It paved the way for the patch as a potential treatment for HSDD. Thank you.